Ladies and gentlemen, tonight I'm talking with Chris Moriarty, and this is a really important conversation because Chris is a doctor. He's done research, epidemiological research related to Brazilian Jiu-Jitsu, and he's been doing Brazilian Jiu-Jitsu for 18 years. I think what we're mostly going to talk about today, Chris, because I'm getting so many questions about this, are guidelines or strategies for reopening the sport of Jiu-Jitsu over the next months and hopefully not years. And I know you've published some guidelines on Facebook. That's how I became aware of you. It was also, we have a mutual friend, Emily Kwok. And but I think we got to start with your bona fides. What's your medical background? Hey there, I'm Stephan Kesting, and this is the Strenuous Life Podcast. What's your medical background?
So I graduated medical school in 2014 from Philadelphia College of Osteopathic Medicine, so I'm a proud DO. I did a general rotating internship as a prerequisite to my residency on Long Island, New York. And then I did, so that was 1 year, and then I did a 3-year physical medicine and rehabilitation residency at the University of Miami. And right now I'm doing a 1-year primary care sports medicine fellowship. And then I will be starting my career as an attending physician at Indiana University starting in August as a faculty member there.
Okay. And you've done some research on BJJ in the past. I mean, not COVID related, but just talk about that for half a sec.
So I started a research project it was like the middle of my second year of residency. So I had 4 years of residency, and basically what we did was we generated I generated a survey that would be kind of get a feel for what are risk factors for injuries that occur over a 3-month period. I wanted to look at a short period of time where we would capture people at a certain level of skill, a certain level of time a certain level of experience. And we wanted to look at differences across experience levels between gi and no gi. And we wanted to look at all the factors that contribute to it: age, previous sport history, how much you compete. And so we ended up with a sample of 1,320. And then in the final analysis, where we actually looked at all the risk factors and patterned out all the injuries, where the most injuries occur in terms of body parts, we had 1,287. And that was published in September of 2019.
On another day in the future, I really want to dig deep into that because I think injuries are the bane of jiu-jitsu. That it's really what stops most people from getting better. We'll save that conversation for another day because right now the bane of jiu-jitsu is something entirely different. You're a black belt, right?
Yes.
Okay. And you used to compete a lot?
Yeah, I mean, I think my biggest years of competition were probably between 2004 and 2008. And then off and on, I started medical school in 2010. And so, I dabbled in it competing when I would get like breaks from very intense periods of like medical school. Or when I had a break between my internship and residency, I was able to get in shape and train to compete. But since then, it's kind of been, so last time I really competed was in 2016.
Okay. Now, I imagine juggling the two things would be incredibly difficult.
Yeah, and it's hard. I don't want to, it's like, I'm 36 now. It's so crazy. But, it's like, yeah, you try to put off, going to the master's division, but, fighting like 22-year-olds for 10 minutes in black belt gi is like, you can't just like roll in there. You got to train hard for a few months, and it just, it's tough.
Yeah. Okay. So before we get to the guidelines that you're suggesting, that are roughly modeled off of the White House guidelines, if I'm reading them correctly, how did the whole COVID thing come to your awareness?
So I can't remember exactly what the first thing I saw about it was. I remember like in the beginning of February, or maybe even mid-February, I made some snarky comment about how like there was something written about how Diet Coke was going to be limited because of supply chain problems related to COVID. And I made like a funny post, but it's the only thing that scares me about COVID. But then I get updates from the New England Journal because I used to have a subscription. So they constantly send you emails trying to get you to sign back up. because the New England Journal is like the one journal that you don't just get institutional access to. You have to buy an individual membership because they know it's valuable. And so I still get things from them, and I was getting a lot of stuff from them, and I was like, wow, this is pretty scary, you know. And I remember being in medical school for MERS, and when there was the Ebola scare, and those things just weren't really transmissible enough. I wasn't ever really that alarmed. It was terrible for the people that were affected, but I kind of, it never really got my attention to something that could become a pandemic. But so SARS was like in 2008, and then MERS was had like a 20 or 30% death rate. That was the Middle Eastern Respiratory Syndrome, and that was like 2012, I think. And also, there wasn't the really long incubation period that could, up to 14 days, that you could be theoretically pre-symptomatic, and so the New England Journal, I think they posted an article, and they never post anything for free, but they posted the case report, the published case report from the first confirmed COVID-19 case in the U.S. And the guy tested positive. The test came back positive on the 20th, and he had been in Wuhan, China. And so I read this whole thing, and the guy was like 30 something, and he had no past medical history, no comorbidities, nothing. And he was sick. His oxygen saturations were dropping. He had bilateral pneumonitis. I was like, Jesus, And so I remember I was going to give a presentation to the athletic trainers, because one of my responsibilities as a sports medicine fellow is to, do lectures for the athletic trainers within the hospital system that cover all the high schools we're affiliated with. And I was going to do it on pediatric low back pain, but when this came up, and I saw that we were having that start of an outbreak in Washington State, I was like, this is too important. Because we were in wrestling season, and we were having a big regional meet. And the Arnold Classic was coming up, and I was like, man, there's going to be people coming from all over. We aren't doing anything in terms of containment right now. So I did a lot of research in preparation for that presentation, and then I pretty much became obsessed with it. And then I told the gym where I trained that, I told them about my concern, and we told people not to go to the Arnold Classic. And then
the Jiu-Jitsu gym where you train.
Yeah, the Jiu-Jitsu gym where I train. I'm sorry. So I teach, I help teach out at my friend John Stutzman and Sean Gray's gym up here, S&G BJJ in Dayton. And I told them, I was like, hey, once there is confirmed person-to-person spread in Dayton, in Greene County or whatever the other county is here, I can't remember, but in the Dayton area, I said, we have to close, because we don't have the testing capacity yet to even know how many other people are out there. So you have to assume right now, if you have a case of person-to-person spread, you're going to have, you could have 10, 20, 30 times that amount. So that was the criterion that we used to close. And then, I'll kind of hold off to your question about the guidelines, but I kind of was waiting for some kind of cue from the federal government about reopening before I came up with these guidelines, because I wanted something concrete to base them on. And you'll see that the phases that allow full return are basically, it's the same criterion that I used to close, we're using to open.
So I don't want to go down a huge rabbit hole here, Chris, because we certainly could. But what makes you? But some people are going to be asking, how do we know this is real? I'm on Facebook. I'm being told this is a fake pandemic. I'm being told it's no worse than the flu. I'm being told this is a huge overreaction. Why should we even have guidelines for closing and opening gyms? The gym should just be open. So I don't want to spend the majority of our time talking about that, but we got to address it. What makes you think that this isn't just the flu and that this isn't a huge overreaction?
So, there's certain people that it doesn't matter what I say or you or I say or anybody says that to convince them. And I think that there's always to any pandemic, there's a proximity issue, and then there's a personal relationship issue that, skews everybody's vision of something. So if you're in a county right now that is relatively isolated and has a very, very, very low burden of disease, you're going to feel one way about it, especially if you don't have a really strong scientific background. You're going to feel one way about it. But if you happen to be someone that lives in Manhattan
or Milan,
or Milan, and actually I have friends in Milan, and it's been really interesting talking to them through this whole thing. But yeah, so if you live in one of those places, you know, what I say sometimes to people is like, however you think you would act here, if you live, like, would that seem reasonable if you were in Milan right now? Or if you were in New York City right now? Like, would that be a reasonable thing to say? And anything that I say right now to try to convince people is going to be anecdotal, because you either believe the data or you don't. You either believe that the average, you know, scientist that drives to the CDC making $60,000, $70,000 in a Prius, you know, he's part of the, you know, medical industrial complex or pharmaceutical industry. He's not making any money. He's just doing science.
I don't think we can go against the die-hard conspiracy theories, because I'm on the take. Have you received your Bitcoin yet?
Exactly,
I haven't. Yeah. So we can address that.
Yeah, so...
But what about this whole idea that if you go to a hospital with a gunshot wound and you also have COVID and you bleed out on the operating room table, that you then died of COVID? Like, so, that's another common narrative that's going around, and you're in the medical system, so
yeah.
Talk me through that.
I mean, you know, fortunately, in my practice right now, or in my fellowship, I'm almost all outpatient. I cover an inpatient unit sometimes, but I haven't been lately because of all of this. But I'll tell you, I mean, you know, when I was an intern, you know, it would be my responsibility. I'm admitting patients. I would have to chart what their diagnoses were, and all those diagnoses have billable codes. And then when somebody would get discharged, I'd again have to write a discharge note, and I'd have to put in all their diagnoses. And if somebody died, it was another discharge note that you write, and those diagnoses were on there. And I've never had a situation where anybody was ever standing over my head saying, hey, you know, this is the primary diagnosis for this patient. Like, you need to do this. Now, interestingly, sometimes there's nurses that float around trying to get you to help you with charge capture, because some people are just lazy with charting. But what I would say is that it's crazy to me to think that of all the things that physicians go through, we wouldn't be able, like, you don't think we'd be able to determine what's logical. So I gave this example before on social media that, and just give me a second to explain this, but you have a 40-year-old guy that comes into the hospital, and he's been in an area with a high disease burden. He comes in, he's had 5 days of up and down fevers, maxing out at about 102, a dry cough. You check his O2 saturation, and it's 87%. He feels short of breath. You can see that he's short of breath. You put him on high flow nasal cannula, so really high flow oxygen. You check a chest X-ray, and he's got this, what we call bibasilar ground glass opacities, which are very pathognomonic or very characteristic for COVID. So this is the early days of the disease, and so we didn't have that rapid turnaround time for tests. Okay, this guy very clearly, by clinical criteria, has COVID. He was in an area that with a high burden. He's got the chest X-ray findings. He's hypoxemic. You know, he's had been febrile, so you admit him. And then you follow chest X-rays for a few days, and they continue to look the same. And then one day, boom, he crashes. You intubate him. You know, you check another chest X-ray. Let's say he's been in the hospital for 7 days. You check another chest X-ray, and this one has, you know, a big lower lobe pneumonia. And then you're like, you know, his fever is like 106. And so you're like, you get blood cultures, you do all the things that you do in sepsis. You know, you get, you know, a bunch of labs, you get blood cultures. What's growing in his blood? Why is this happening? The guy dies, despite all of your best efforts. The next day, the blood culture results come back, and it says, you know, multi-drug resistant Klebsiella pneumonia, which is a possible, we call nosocomial infection, or a ventilator-acquired pneumonia that became septic, right? And I forgot to say...
That's a bacteria. It's not a virus.
Bacteria. So I forgot to say that the day after he admitted, his COVID results came back positive. So this guy, right, he had COVID. He was doing okay. He ended up developing Klebsiella pneumonia, became septic, and died. So if you asked me, would I say this cause of death was COVID? Absolutely. There's no other reason that this 40-year-old would have been in the hospital with low oxygen saturations, with bilateral ground glass opacities, and having to be in the hospital sick for long enough to develop a very common hospital-acquired infection and die. So did he die from pneumonia? That was the cause of his immediate death. But what was the thing that really caused him to have that decline? It's COVID, obviously. Now you contrast that with somebody else who, He walked out in front of a bus, got hit. He's got pulmonary and cardiac contusions. He's got multiple rib fractures. He's got a pneumothorax. He lacerated his spleen. He's bleeding out. And then you happen to test him for COVID as part of the screening because of your hospital. The guy ends up, dying from, blood loss and just trauma. And his COVID test comes back positive. Should he be documented for COVID? No. And nobody's going to make that mistake. No physician is going to make that mistake. It's just, there's sometimes where it's just, you have to just think about everything that we've gone through to be able to make these kind of determinations. And it's really, it's actually, if you step back, it's, as a physician, it can be, very rarely can be confusing. Most of the time, it's pretty logical.
There's also that data that I first saw in the New York Times. It's also comes from the CDC, showing the excess deaths, right? So on the one hand, there are definitely some people probably getting tagged as having COVID being the cause of death when it's not really the cause of death. On the other hand, there are all these excess deaths where, in a normal year or in a normal month in New York City, I'm making these numbers up, something like 1,000 people die. But in February, March, and April, a much higher percentage of people died. And it has been borne out across different cities. Now, you can make an argument that all those excess deaths are things like suicide and drug overdose. But
what would you have to, you'd have to, if somebody died of a suicide, that would be something that'd be very easy to determine in the chart. Nobody's going to, make that mistake. There's going to be, if the incentive for all of us is to just make everybody COVID, you know what I mean? If somebody says, okay, then somebody looks back and say, oh, we can attribute all those excessive deaths to something other than COVID, right? Like that kind of goes against the whole theory that we're trying to inflate COVID numbers, right? If somebody commits suicide, they commit suicide and they die, it's going to be suicide. It's going to be, self-inflicted injury.
Yeah. I guess my point is we're missing people. We're diagnosing some people as having died from COVID who might not have died from COVID, and we're certainly missing other people who did legitimately die from it, but it presented as a heart attack or a stroke, say, as opposed to the classic signs of COVID.
I mean, it's really the one thing that's just, I think it's the best way to look at this is if you look at Italy, if you go to that Worldometers and you look at their curve, it's a beautiful epidemiological curve. You see there's that lag time where it takes for enough cases to build up for the caseload to explode. So it goes like this, boom, and then it goes up. And then once they get control, it's plateaus, and now it's very slowly dropping. And then if you go to, let's say, Britain or the Netherlands or some countries that came by afterwards, you see that same sort of trend, but lagging a little bit behind. I mean, all these epidemiological curves look, there are abnormalities, but they all look fairly similar. And if it's not all the same thing that's happening everywhere, how is this happening? How are we all coordinating to generate these fake epidemiological curves that are just, they look exactly like what you would see in an infectious pandemic,
All right. So that's about as far as I'm willing to go to debate the conspiracy theorists. I'm sure most of them have stopped listening by now anyway. So let's get... I became aware of the suggested guidelines that you put out on Facebook, and I'll probably put to them I will put them in the show notes if that's okay with you. They seem to be based off the White House Return to Work program, essentially, the sort of the opening up America.
Yeah.
And that's kind of based on a 3-stage program, right?
Yeah, so 3 phases.
Yeah, 3 phases. So can you take us through those 3 phases, and can you take us through how that applies to Jiu-Jitsu? Because that's a sport you know very well. When I came out fairly early in this, saying that really there's no better way to spread an infectious disease other than maybe group sex.
Yeah, that's exactly. I was like, what's the worst? Think about the worst possible thing you could do is, and then try to find something worse than jiu-jitsu. Like it's
maybe an orgy.
Yeah, exactly. I'm with you. I didn't consider that one. Yeah,
but other than that, I think we're a very close second. And I don't want that to be true. I have a vested interest in the health of the sport. I've been accused of stoking fear here for financial benefit for selling online programs. I'm telling you that those aren't doing that well either. I have no vested interest in this. But let's talk about how we're going to get back to normal. What's a reasonable approach to get back to normal, and what are some of the caveats around what you're suggesting?
So we had kind of talked, I mentioned at the beginning of like how, there was a lot of angst. People were, waiting. I feel like a lot of academy owners, especially outside of the mid-Atlantic area where the initial, explosion happened, people were just kind of sitting there for the first few weeks waiting for it to happen. And then when it didn't happen, people, started to look back at their academy and the money they were losing and the members they were losing. And they started thinking, okay, we have to do something. We have to open, like, what's going on? And I was thinking, man, this isn't going to last forever. People aren't just going to sit here and not do anything. But we hadn't gotten any guidance. There was not any talk of trying to reopen. And then Trump started hinting at it. And then it was it 2 or 3 Fridays ago at this point? I can't remember. But finally they released these guidelines. And I remember I saw them at work. I printed them off and I looked through them and I thought, these are very logical. And why to me did they seem logical? Because they weren't based on any dates, right? It's a
roadmap, it's not a calendar.
Right, because what you need is to demonstrate that you're winning. You need to demonstrate that the measures that you're taking are having an effect, and that how you can get this under control. Because let's say you move into one of the phases, you start to lose control. If you go back to this place, you can get control. So when they released those guidelines, I think like the next day or the day after that, I sat down and I was like, okay, how can we make this work for jiu-jitsu? Because one of the things that concern me about the guidelines are not only the guidelines, but what the Georgia governor had started to suggest about, one of the first things that could open or were like gyms were somewhere in there. And I was like, man, these people that are just kind of, these jiu-jitsu academy owners are going to think, they're trying to grab on anything that'll allow them to keep their business. And I don't blame them. So they're thinking, okay, it says gym, that applies to me. And just like we were talking, it just doesn't. And so I was like, man, somebody's got to put something out that will give academy owners something that they can hold on to be like, okay, we have a plan now, and something they can show their members so their members go, okay, I see a way back. Because that's important, right? If you're a member and you're not getting any communication from your academy, or your academy owner just keeps saying, well, wait, and they don't have a plan, I get it. And so basically what I did was there's 3 phases in Trump's guidelines. And at each phase, they become more and more and more relaxed in terms of the people that can go back to work, the things that are going to be open, the amount of exposure that basically how much exposure is reasonable in a certain area. And so they're based upon what they call the gating criteria. And the main gating criterion is that you have a decrease, and they think they go by state. But I think you can do this at a more local level, because there's nothing special about states. If you can cross a state boundary just like you can cross a county boundary. So the more local, especially the more rural you are, the more I think you can shrink it down. So basically, the main gating criterion is that you have 14 consecutive days, on average over the last 14 days, you've had a decreased number of new cases per day on average. So it's not that your total active cases are going down. That's not going to happen, because active cases can take 2, 3, 4 weeks to resolve. So that's not important. It's not who you already know that has it and adding to that. It's how many new people you're adding per day. So either the number of new people you're adding per day is going down as a trend, or if you've significantly increased your testing capacity to where last week you could perform 1,000 tests, this week you can perform 5,000, of course you're going to have more positives. But is the percentage of the tests that you're doing, the percentage of those coming back positives going down? So if those are the case, that allows you to move from one phase to another. So, and if you can maintain that, it allows you to become more and more liberal with your exposure.
From phase 1 to phase 2, from phase 2 to phase 3. Yeah, I saw those guidelines as well the day they came out, and I thought they were pretty good. I mean, I didn't read the detailed documentation. Perhaps it got addressed, but my only real concern there was that wasn't much mandating around testing. It didn't say thou shalt do this many tests or there shall be this much testing.
So I think that, they were kind of caught between a rock and a hard place, right? Because they knew that they had to get something out. They knew that it had to be based upon science, but they couldn't, and obviously testing would have been ideal, but they knew that they couldn't have known at that moment what the capability, what the capacity was going to be in a few weeks. And so to push it off anymore until they had that answer, I think would have been a mistake
the testing
too.
capacity.
Yeah. To where they could say, okay, we know we have enough data on tests to be able to include them in our guidelines, right? So I actually think that it was better that they released them at that time and then maybe, gradually modify them than to wait until they had that. And
fair enough.
You see, that's kind of true with my guidelines too. And let me there's one thing I want to circle back to. So in terms of, and I'm not going to beat this over there, this is the last thing I'm going to say about the conspiracy thing. It's, people will say that, Trump is his own thinker and fire Fauci and fire Birx. But obviously Trump finds them very compelling. All the sources of different people in his ear telling him, don't listen to these people, fire Fauci, he doesn't care about this and that. I mean, despite all their public, somewhat public disagreements, they're still there. He's still really listening to those people. So either they're just brilliant liars, or he's finding what they're telling him is very compelling. You know what I mean? So I think that if you're one of the people that really supports Trump, I think you got to support the fact that he's doing the best job that he can. And despite how you may feel about these people, he finds the data that he's getting from them, the information, the way they're conveying it to be very compelling. Anyway, so those are the 3-phase guidelines. And what I wanted to do was I wanted to say, okay, you're not going to be able to open Jiu-Jitsu Academy for rolling right away. And so what I did was I said, okay, the first phase is going to have to be somewhat non-contact. And I'll get to why that is in a second. But I knew that if I put out some guidelines, I said, okay, phase 1, group or instructor-led solo drills, that if all of a sudden all these people rush back into the academy, they would have no infrastructure to do this. Nobody's ever done anything like this before. Mm-hmm. So I was like, okay, use that first 14 days to make sure that you're seeing that trend, right? You're going to have 14 days even to get into phase 1. Once you get into phase 1, say, okay, we're in phase 1 now. We're going to set up our academy to facilitate phase 2. So that means you're going to have people, you're going to need to screen people at the front for symptoms. So that means that you're going to check temperatures with I think it's probably easier to do a temporal artery thermometer. It's more sanitary, it's easier. And I put some
What does a temporal artery thermometer look like? It's not the heat gun, it's not the ear gun.
Yeah, it is. It just goes right here, right? Okay. You can put it here or here, okay. Right? But it just depends. I mean, I've seen people initially go like this. They start here and they go like this. They put it here and they put it here. It's just a superficial thermometer. It's the quickest. Now the problem is that it is off. It registers a little bit lower than an oral thermometer, so about 0.5 degrees to 1 degree. So I put a correction for that in the guidelines. So instead of the cutoff being 100.4, it's 99.3, right?
So above 99.3 Fahrenheit,
Fahrenheit. I don't remember what I put it in there in Celsius too, but I can't remember, Okay. But it's in the guidelines.
Chris, I just want to say go as granular as you have time for. Like there's so many academies, it's literally life and death for them.
Yeah.
That if you spend 10 minutes talking about different kinds of thermometers, we're talking to those people, okay, that's valuable. Like as granular as you want.
Yeah, so I think that a temporal artery thermometer is the easiest because it's the easiest. It takes the least amount of time. You basically just put it over the artery, hold it, it beeps. You got your test instead of having to put a thermometer under somebody's tongue, hold it there for 5-10 seconds, and then you got to make sure you take the disposable sheath off. You got to put another one on. That's another expense, and it's also, that person's constantly reaching towards somebody else's mouth. I just don't think it's ideal. So a temporal artery thermometer is what you would want. So you have to have somebody at the front, whoever your office manager is, maybe. They're going to be screening people. So you're going to have to, that person should be wearing a mask. Ideally, if you could have like a regular surgical mask, that'd be great. But if that's not possible, whatever cloth mask you have. they're going to be checking temperatures.
And they're wearing a mask because they're coming within 6 feet of somebody.
Right. Well, somebody's going to be coming close to them, right? They're going to have to be, yeah, exactly. They're going to have to be doing the temperature. So you're going to be within 6 feet. So they should also have a list of questions or a symptom checker, right, that you should have. Have you been around, and then a social history screen. Have you been around anyone that you know was tested positive for COVID? So that means if you're a healthcare worker and you're working around people that are testing positive for COVID all the time, you don't meet criteria for phase 1, right? So have you been around anybody that's tested positive for COVID? Do you have any immunocompromising issues? And I put a whole list there that would qualify. Or do you live with someone that is one of the high-risk populations? So if either you or the person you live with is in a high-risk population, you also don't meet criteria for phase 1. So it's social history screening, a general medical history screening. Do you or are you not in one of these groups? And then you check temperature and check symptoms: cough, fevers, chills, nausea, vomiting, diarrhea. If none of those things,
so COVID test itself or an antibody test itself, there's just not the infrastructure capacity for that at this time.
I'll get to that in a little bit. But so that person meets all the criteria. So that's one thing you have to set up. Whoever's going to be doing the screening needs to know what's required of them, needs to know, how to check temperatures, making sure that when people are coming to the door that they're spaced out. That person needs to have a plan for how they're going to do this. Where are you going to put your table? Are you going to still be behind your manager's station? Is that going to cause a buildup of people, between the door and the desk? Are you going to be outside? You need a plan for these things. And then you need to spend some time demarcating your mat, because for the phase 2, you want to have at least 36 square feet for a person that's 6 foot by 6 foot, so you can spread people out in the mat. So you got to determine how many people you can fit on the mat and what are the requirements for your area for the total amount of people you can have in an area. If your place says you can only have 10 people, then maybe your mat could fit 20 people with the spacing guidelines, but the county guidelines for total number of people are going to trump that. So you got to know that. So you got to check with your county, you got to check with your city and figure out what the rules are there. And so then you demarcate the areas. You figure out what your schedule is going to be for cleaning. You figure out, you got to set up an online tool that people can access to register for classes that's going to close once you reach the total number, the maximum amount of people you can put in your mat, or the maximum amount of people you're allowed to have. And then do you need someone that's going to be making sure that people aren't bunching up, that you're not having more than one person in the locker room at a time? So maybe people should come with their, rash guard or shorts underneath their clothes so that they don't all have to go in the locker room, and then you have your instructor there. And so there's so many things that you need to think through that are going to take you a little bit of time before you're ready to open. If you don't have an online scheduling system, you're going to have to build that in. And so I gave that phase 1.
And you'd also need, in your checklist here, I'm looking at it right now, you're saying hand sanitization stations.
Right. So anybody that comes in, so what we do at the hospital is or even my clinic, when you walk in, there's a hand sanitizer. The person's checking you in wearing a mask. I'm wearing a mask. Most people come in wearing a mask, but not everyone. And then I clean my hands, and then I log myself in as an employee. The patients don't have to do that, but I log myself in. But it's not really helpful if I grab the pen before I clean my hands, right? So there's that issue too. So you should have a hand sanitizer right there. So when people are coming from their cars, they clean their hands. When they come off the mat, go onto the mat, they clean their hands.
They clean their hands before they open the front door of the gym. We're dealing with all these exact same things with the fire hall, and we've come up with many of the same solutions. So
yeah, so this takes time, and especially if you're not in healthcare, you're not used to this. You guys, all the people that work in the academy, are going to have to kind of put their heads together and look at different things and think about, how many people do you have? Do you need to? Maybe somebody that hasn't been working, you need to bring them back in to help you a little bit. There's a lot of things you need to figure out. So that first phase is for that. Now, let's say you've gone through the first phase. Then you're ready to enter the second phase because you meet the criteria. So then you start the instructor-led solo drills. And people are saying, a lot of people are saying, well, what's the point? If you can't roll, then there's no point in coming back. Well, I think that for some of the people that, if you've been doing jiu-jitsu for 20 years and you're not an academy owner, maybe that's true for you. Maybe you're like, I don't want to come in and do a bunch of instructor-led solo drills. But for the beginners, the people that have been training for, less than a year and still need, or even 2 years, and still need to if you're doing a hip escape, I want to see you do the hip escape without your hips on the floor. I want you to see you stay in a bridge and be able to do a hip escape in place. That's a skill. And you can't get that feedback when you're at home. So there is a benefit to having somebody be able to give you feedback by watching you. And just the whole act of coming into the academy, building it back into your schedule, being like, nah, I got jiu-jitsu at this time, it starts to become part of your routine again. So I think that there's really a value not only for the members, but for the instructors in terms of retaining students to build that routine, to get that routine started back in people's lives. So I think it is important to do that. And that feedback is really important. You can do class online, but can't give that same kind of feedback as when you're in the same room.
A couple of questions here, Chris. The first is the basic general rule of 6 feet of distance is based off of you and I walking outside. It's based off of you sitting at a table and me sitting at the other end of the table. It's not based off of both of us doing cardio and going and spraying droplets all over the place. So is that 6 foot distance sufficient for exercise? Do you know if there's any data there?
That's a fair question. I think most of the people that I know that Alliance Academy, where Alliance headquarters in Atlanta, where they're implementing it, they're using more than that. I think they're using like 10 by 10 or 8 by 8. No, I think that's an interesting, it's a reasonable question to have. I'm not saying, you got to take risks, but that's one reason why, just to even get to phase 2, right? In theory, from the time that you started looking at the cases, that's really 28 days. Now, where we are right now, you could be way further along, if you've been following everything. But from that, so by the time you get to phase 2, you've had, 3-4 weeks of consistently declining cases. So, it's still, it doesn't, nothing that we do here could completely eliminate your risk. But I think that in that situation, by the time that you're in phase 2, if you maintain that distance, okay. Is it foolproof? No. If I could go back and do it, would I say, do I recommend maybe taking a little bit more room? I think it's reasonable, maybe like 8 by 8. But I don't want to also at the same time say that this one academy said, well, I don't have enough mat space for that, so I can't do anything. I'm trying to kind of walk the line,
And who knows? New research could come out next week and says that 3 feet is enough, or it could come out and say you need 12 feet.
But also you have the screening at the front. So these people that are coming in have no known contacts with anybody that has it. They have no immunity.
They'll admit to. So if I really want to train jiu-jitsu, I'll lie.
Well, hopefully, that person's probably going and rolling with his friends in the garage somewhere anyway. He's probably not going to come in and do the solo drills, But there's nothing that we can do.
Okay.
Foolproof.
So 2 more questions regarding the distance and would wearing something like a cloth mask, if I'm huffing and puffing, as I'm on rep 85 of, the S-mount armbar on a dummy in my little 6 foot by 6 foot thing, would wearing a mask prevent me from spewing those droplets as far?
It's a good point. So I've kind of thought about this a little bit. It's like, now if you have a mask that's really well fastened to your face, then I think it's something to consider. My only concern would be if you wear a mask, you would never want to do something like that with an actual respirator like N95 because you're gonna build up so much carbon dioxide, you're actually gonna cause yourself to pass out, right? Anything that you have over your face is going to prevent you from being able to, you're going to be breathing in a lot of your own expired air. And the harder that you breathe and the more CO2 that you produce, the more sensitive you're going to be to that problem. So I would say that it's tough, if you have very limited space and you can only do the 6 feet by 6 feet, maybe try it, again, you got to figure this out with your academy. Okay, we're going to keep these drills really short and see how people do with the masks. Are they, because people are going to be deconditioned too, right? From not training. A lot of these people haven't done anything. So keep the classes short initially, see how people tolerate wearing the mask. But if you were able to do 10 feet by 10 feet, maybe you don't need it.
Okay. So second question, and I know that, say, in hospital waiting rooms and hospital operating theaters, they have a minimum standard for the number of air exchanges that have to happen in that space, right? You can't have like I forget what it is, but every hour, 10 times the volume of that space has to come in with fresh air and basically to keep the flow of air going. So do you think that there's a purpose in keeping the doors open or turning the ventilation up to full just to keep fresh air movement, or is that going to spread?
Yeah, it's hard
more?
because I don't know if you saw that there was that analysis of like
the restaurant in China.
Yeah, right. The restaurant.
Where it
it was like
the HVAC system.
Right. Yeah, and so yeah, it's a good question. I mean, again, that's one of the reasons why I would say, like, let's say that you're in an area and you haven't started your 14 days. You haven't even started. Like, you're not there. You could not just jump into phase 2 right now because the disease burden is still too high. You're not doing anything to bring down the cases in your area, right? At a certain point, you get safer and safer the further out that you go. I don't know if there's a good answer for that. If you could keep a door open, to me it seems logical. If you could do that. And obviously you're going to limit the amount of people that you have in the space. But if you can keep doors open, it's probably better than just recirculating air. But I don't have any data.
Obviously in a hospital operating theater, that air is not only recirculated, it's filtered.
Yeah.
I'm not sure that's the case in most HVAC systems.
No. Yeah.
So, okay. So there we are in phase 2. So we're basically talking solo drilling. We're taking all the precautions that you mentioned. We're talking solo drilling, maybe drilling on a dummy if your academy has enough, or if I think Gracie Baja was saying you had to make one and bring it in with you. So you had to drive in with your
one thing that I didn't put in here that I think could be reasonable is, let's say that you happen to have quarantined with your spouse or your son and they do jiu-jitsu. You want to come back and be able to do some drills with them. If you have a big enough group of people like that at your academy, then you might have to consider maybe giving a different class for them, right? Because they are going to require much more space, right? If 2 people in one space is going to require a much larger separation. So I think those people that have been quarantined together, right? There's no benefit in forcing between just those 2. Like you can't say you can't train together when they're going to get in the same car and go home.
I'm just trying to picture 4 training buddies deciding to for the sake of training, that they're in a polyamorous relationship.
Yeah, no, it has to be someone. It has to be someone that you've quarantined with the entire time, and you have to gauge your own academy. Like, these people trustworthy? You could say, "No, we're not doing that," or you could say, "Okay, we've got like 4 different dads and sons that live together, and they started jiu-jitsu together, right? Sure. They just want the mat space to drill. Okay, those people are gonna have like a 10 or 12 by 12, and they can only come at this time." Right. That's just a very unique situation that I didn't put in because I didn't want to complicate everything.
Right.
But that could be done in phase 2 as well.
So are there any other considerations or precautions that we need to do in phase 2? And this your phase 2 maps exactly onto the White House's phase 2. So basically when the state says, or the township or the municipality says, "Hey guys, we're in phase 2," that's when your academy goes to phase 2, or does the academy make its own decision?
That's only, I would say, only if you've actually done everything that you needed to do in phase 1. So let's say that you're in a place that, and all of a sudden you look up and you're like, "Oh my God, we've been in phase 2, I didn't realize." I would still say that you need to, however long it takes you, maybe it takes you only a day or 2, you need to take the time to determine everything first. You can't do this in real time. You need to figure out how you can set up everything that's listed in phase 1 so that you can be ready to go into phase 2.
Well, in the show notes, which I guess will be at grapplers.com/Chris Moriarty, and I'll link to it in a few other places as well. I'll include both the White House guidelines and your guidelines.
Yeah.
I think it's worth pointing out that other countries don't have 3-phase openings. I mean, Canada and a bunch of provinces have gone with 5-phase openings. So you'd have to adapt, and hopefully the ideas that you're putting out here will map over somewhat to that.
Yeah, exactly. That's why, these are really specific to the United States. Somebody asked me earlier today, how do these compare to guidelines you've seen for judo and stuff? And I was like, honestly, I didn't really look. Judo is a much more international sport than jiu-jitsu. Maybe not now, but in terms of how widespread it is, how many people you have going to the Olympics in all these countries. And every place is so different in the rules there and their disease burden. I couldn't even get into it.
No, I just saw the Australian guidelines for resumption of they have a 3-phase thing for sport. And I think phase 1 in judo and phase 2 are basically non-contact judo. So you can do like uchikomi on bands.
Judo's much easier to do solo drills because they can do all the groundwork that we do, probably not as well, but man, yeah, like in terms like you can do so much with standalone uchikomi with bands and gis and stuff, It's gonna be boring, but
well, I mean, maybe eventually, maybe this will finally be the impetus that jiu-jitsu guys need to develop a few takedowns.
I think that's great. If you could start implementing some uchikomi, that'd be an awesome thing to do.
So phase 3 is another 2 weeks of no increase in cases?
So basically, phase 1, phase 2, and phase 3, to enter phase 1, to enter phase 2, and to enter phase 3 are all the same. The gating criterion is exactly the same, right? It's decreasing number, on average, a 14-day trend towards decreased number of new cases per day. Not active cases, total active cases again, but new cases per day, or a relative decrease in the percentage of tests that you come back as positive if you've increased your testing capacity. So to enter phase 1, you have to have that. To enter phase 2, you have to have that. To enter phase 3, you have to have that. Now in phase 3, what I did was I said, okay, if you're in an area where there hasn't been any new change in testing capacity, and the only people that get tested are healthcare workers, people with symptoms, or essential workers, or people that have high risk for exposure. If you're in one of those areas that's all it is, phase 2 is going to continue. But I kind of anticipated, and I'm anticipating that obviously what's going to happen is what we need to have happen, because if we know what the delay is going to be like in the vaccine and the lack of reliability so far with antibody testing, is that they're going to need to dramatically increase capabilities or capacities for RT-PCR so that people can know, okay, I'm negative now, I can go to my job today.
So RT-PCR is checking whether you have COVID or checking whether you have antibodies?
Checking whether you have COVID. It basically looks to see if you have viral RNA in your body.
So let's take a quick break here in between phase 2 and 3, not for a word for our sponsors, but for you to explain the state of testing, because I think people get confused with the difference between testing for COVID versus testing for antibodies. And they get really confused when you start talking about the false positives and false negatives and the implications of that, both on things like the infection fatality rate and the prevalence of this in society.
Right. Okay.
And the availability of testing. So that's if that digression takes us half an hour.
No, I think it's good. It's good. It's important. I forget. It's like you're so used to saying these words, and then you don't think about like why would you know if you're an engineer and some of what RT-PCR is? But
I promise that I will not let you go before we go through stages 3 and
okay, good. All right. No, I know. Basically, what you're looking for with the screening test, the test that we have to see if you actually have the virus, if you have viral particles. If virus is replicating, right? We take a swab of an area that we know we believe there's going to be a high amount of virus, right? We know that the virus, is aerosolized, it comes in particles, and we breathe it in through our nose, and it comes through our nose, and it goes into our respiratory system. So the initial test that they were using was a nasopharyngeal swab. So they take a swab, they put it all the way back in your nose. So people don't realize that all the way back here, your nose ends in a tube that connects to your mouth and your throat all the way down. So if you push a swab far enough back, you're going to hit the back of your throat, and they're able to sample and get, if you have, COVID virus, you're going to capture it. And then what they do is they put it in for lack of a better word, like a soup that it has all of the building blocks it needs to replicate its own genetic code, its RNA. And then you put that in a soup, and then you follow it, and you see, if you started with this much of virus, you look over here, wow, okay, it's been able to replicate itself a lot. And that tells you the, amount of replication it does, what the disease burden is, or how much virus you have in your system. Do you have enough virus for it to really be considered significant? And then that is what we use to determine, okay, you tested positive for COVID. Now, I'm not a immunologist or molecular biologist. I'm sure somebody can explain it in a much more scientific way, but it's basically we're trying to see if a virus is going to use all these building blocks to make more of itself, to make more of its
So right now it's a fairly invasive, fairly technical test.
Yeah, so
your jiu-jitsu instructor cannot do a nasal swab.
And the thing too is one thing that was worrying to me was they're talking, I don't know if this is still a thing, but people talk about at-home tests for this. Now, if you're going to do an at-home test for pregnancy, right? Fine. I mean, that makes sense, right? It only really affects you, whether or not it's positive or negative. If you want to sabotage your own test, that's fine. But when you have an incentive potential incentive to sabotage your own negative test to be able to go back to work, I'm sorry, unfortunately, I don't trust people to do this at home. Number one, just technically, I don't think I'm willing to trust people, at least the way it is now. Most people, I think they were just talking about doing a regular nasal swab. Nobody's going to be able to do their own nasal pharyngeal swab. And number two, it only takes one or two people with a bad motive, to want to get back to work to be willing to falsify a test. And so right now the tests, I think, are really I think most of the swabs that we're doing are nasopharyngeal swabs, and I don't think that there should be any home testing. So that is the test to let you know that you have the virus, that you are infectious, right? That's the test to say, okay, you have this, you need to self-quarantine, you need to stay home, you need to isolate. You don't need to be out, even within 6 feet of anybody, you need to be completely isolated. Or if you get deathly ill, then you go to the hospital. But even if you have a positive test and you're only minimally symptomatic, you still shouldn't go to your doctor or the hospital. Call your doctor, tell them the symptoms that you're having. They can kind of coach you on what to do. So that is the RT-PCR. It's a real-time polymerase chain reaction. And the second type of test that you have is serology, or it's antibody testing. And basically, all we're looking for there is, do you have antibodies did your body produce antibodies to the virus? And so that tells you whether you were exposed and generated a positive antibody response. So now the question is, there was some questions about, are antibodies really protective? And there was I think in Korea, they were saying, people that had developed antibodies after recovering from COVID, they were found to have, a positive test for COVID via RT-PCR. And I think that the latest data came out and said, well, we were detecting viral fragments. Yeah. And they weren't really sick, right? They never had any symptoms. They never developed a fever. They never progressed. And so that's a problem, right? With the screening test, though, it's never perfect. So you're always trading, right? Specificity for sensitivity, right?
Yeah, and it basically, there's a high false positive rate on that.
So let me step back for a second. So with any test, you have a balance between sensitivity and specificity. So sensitivity would be, how sensitive is the test? Like, it's not going to miss. If you have a test that doesn't miss anyone, then you are going to diagnose people that don't have it as positive, right? That's just the nature of it. If the test is super sensitive, if you have one viral particle, you're going to test positive, right? Well,
or it's a different coronavirus.
You're inadvertently going to, it could be that too. You're inadvertently going to end up with a whole bunch of people with false positives. But then if you make it super specific, meaning that you have to have this many viral particles, a big number, because we want to make sure that we only capture people that are really likely to be sick, you're going to miss a whole bunch. Right, and there is no perfect test, and I was trying to look up some data on that, and I sent some things to you about the false negative, because the big issue with a screening test would be false negatives, where the big issue with an antibody test would be false positives, right? Because if you have a test that you're trying to see if you're infectious, and you have false negatives, that's a big problem, because now you feel empowered that you can't give it to anyone. Whereas if you have a test that you're seeing if I'm protected, right, if antibody test, and that tells you you're positive and you're not, then you feel like you can go out there and not get it, right? So it's kind of different competing interests, things that are more worrisome with one test versus the other.
Immunology, it's complicated.
Yeah, it's just, it's tough. So, but I tried to look up some numbers on the false negative rates, and I really couldn't find all that much. But so one of the things about the guidelines that just happened to work out was that that isn't even really discussed until you're in phase 3. So by the time you're in phase 3, you're going to be hopefully Not every virus is the same, but you're going to be in a pretty good level of control of the decline of the virus. You're going to have fewer and fewer and fewer new cases circulating. So if you test negative in a situation where the disease burden in your area is really low, you can have a little bit more confidence that that's a real negative. Now, if you're in an area where cases are exploding all around you and you have a negative test, are you really comfortable to 100% sure that you're negative? You know what I mean? It's different. So it depends on the amount of cases that you have around you. So I think that, and again, an epidemiologist would be much better explaining that, but when you get to phase 3, that's basically where I start to even talk about looking at you're testing positive or negative for the virus. And what I basically say there is, can we go back on that now?
Sure.
Okay. So basically what I say there.
Phase 3.
So basically, yeah. So in phase 3, if you don't have increased testing capacity in your area, and the only people that can get tested are people at high risk with symptoms, so that high risk healthcare workers or symptoms or people that are in essential jobs, those are the only people who can get tested. You're going to stay in phase 2. You're going to stay in phase 2 until you either reach phase 4, right? If you had to skip over phase 3, or until the area that you live develops enough testing capacity such that anybody that wants to get a test is able to get a test. So like in LA County, they started it, was it Monday or Tuesday, that you register online and you can go drive up and get a test. Now, I think there's still some criteria, like are you at risk? It's starting to open up, and more and more places are going to start to do this. Tests are going to become easier to do. We're going to, the big issue at the beginning too is, do we have enough reagent to run the test? Do we have enough of the testing supplies to run the test? Now that, that is starting to be scaled up, capacity is going to increase. And so if you get to a point where in your area, you can get a test that's reasonably affordable and it's quick, the turnaround time for some of the tests are 15, 20 minutes, then it's possible for you to say, okay, I'm going to get this test negative. I'm going to go straight to the gym. I'm not going to go out. I'm not going to go to the grocery store. I'm going to go straight to the gym, and I'm going to show my proof of test from this day that says I don't have the virus. And then you can have a group of people that are willing to do that. Now, I don't think that it's really reasonable or affordable or even a good use of resources to be doing this every day. But you can imagine that maybe in phase 3, you could say, okay, we're going to have 1 day per week of group classes for people that can go and do this, right? So not everybody's going to do it. So like you could say you're going to have the class at 6. These people are going to all have to get their test right between 5 and 5:30. So not everybody's going to be able to do that. And then maybe as it gets easier and easier, you can say, okay, we're going to have 2 group classes a week. But every time you go to the group class, you're going to have to get tested prior to going back. You have to get tested to go in.
But now we're talking a regular group class, warm up, drilling with a partner. Spot.
It would be, so you'd have that group of people that, whoever could show up, that group of people that they all just got an RT-PCR that was negative for COVID. So those people at that point, right, because now we're 14, 28, 42 days out from the decline. We're declining over 42 days at least, right? Because you could spend more than 2 weeks in a phase, right? If you're in phase 2 and that previous 2 weeks, it didn't continue to go down, you had a little spike, you're going to have to wait another 2 weeks. So you know what I mean? So it could take a significant more time than that. But yeah, essentially those people would be allowed to train in a group. The group would be separate. It wouldn't be like going on at the same time as the instructor-led solo drills. Now, of course, how many people you could have in that class, I would probably still limit it to like less than 10 people or less. And then you have to look at, again, what are the county's rules? How many people can actually be together? Are they going to even allow you to do it? So at that point, maybe it's good that if you're an academy owner, you reach out to your local Department of Health. Maybe you can do it at the beginning and say, listen, here are these guidelines I have. This is the plan we're going to have to follow them. We have somebody writing down the number of new cases in our area per day. The student that travels the furthest to come here lives in this area. We're also tracking that data. And you present all of this and you say, this is our plan. And I'm not going to say what to do. Maybe some people are going to say, if I don't hear back from you, I'm going to assume that you accept it. Or I'm not saying to do that, but I can imagine some people will. But it's just good to be in communication with them to say, okay, hey, we've reached phase 3. This is what we're doing. Everybody's getting tested. Can we implement this?
What about people who've already had COVID?
So this is the special population section that I put at the very end as like an addendum. So in my opinion, because of the state of the antibody testing, so right now, I sent you the link for is the FDA, it was all the tests that have gotten emergency use authorization from the FDA since the beginning. And there's a big list. Most of them are RT-PCR tests. So most of them are testing, screening people for the virus. I didn't go back and count today how many there were, but when I went and looked at last time, like a week ago, there were seven serological tests that had gotten emergency use authorization. Now, there's probably 100, 150 serology tests out there that, unfortunately some healthcare providers are selling. Now, these haven't been given emergency use authorization. They're not validated. They've only had, the lab that developed them ran their own studies, if you will, right? But it's in their interest to make sure that...
Yeah, we promise this test works. I mean, I'm in hazmat. We run into this issue all the time with some salesmen swearing high and low that this is the best device, the best test ever, and it's crap.
And so my issue initially was, okay, first of all, the only tests that are going to be valid or they're going to be even worth using are the ones that have been cleared for emergency use authorization, because that doesn't even mean necessarily that they're the most reliable test that we could have. They're just the ones that were the best that we're willing to use right now in this emergency situation. So right now, because we don't know what the false positives are, we don't know that yet. Fortunately, in some places like in Georgia, they're doing like 2 counties. They're going and knocking on people's doors and getting antibody tests, and they're submitting that to a federal database. And we're going to try to see what the prevalence is. I don't know exactly how they're going to have to do something else to test for the accuracy of these tests, but fortunately, they're starting to work with, testing these. But because we don't know how reliable those are, I purposefully left them out of my guidelines because I don't think that there's any role for them in taking somebody that had no sick contacts, no known COVID contacts, and was never sick themselves, that you can take that person and say, okay, you got a positive test, you're good to train. Because we don't know, the test could be a false positive, and then they're going out and they're exposing themselves to everyone and they think that they're fine and they're not.
There's a difference here between Stephan, who got super, super sick, went to the hospital. They tested me for COVID. Yes, I've got the COVID virus. I get better. Then they test me for antibodies. Yes, I've got antibodies. So there's no doubt that I actually had COVID. So there, I'm good to go. But as opposed to somebody who got out and got, quote, tested for antibodies with some test that you and I, we took a bunch of pregnancy tests, put a sticky note on it, called it a COVID test, and sold that. That's actually a great idea. I got to talk to you at the end of this interview about...
I'm down.
You're saying that we shouldn't trust the things that haven't been approved. Was it who approves those tests? Is that the
FDA? I don't know the whole approval process, but the FDA is, like I said, they're giving...
I'll include the link.
Yeah, I put the link in there, and they have, you can go through the whole thing of how they do it, but they give all the specs for all the tests, and it's not just from one company or another. I mean, like I said, most of the people that work in the FDA, like we talk about, most of these people that work there, or like the scientists, they don't make any money. They have no interest. They're just trying to do the best job that they can, and they're getting inundated with information. But the point that you made is, what you were saying is the exact point that I was making, that even when, Dr. Fauci has been very, very measured in everything that he says about whether something's going to be effective or whether this test is going to work or that. But even he and Dr. Birx were like, in everything that we know about virology, and all the, diseases that we've studied, if you had an illness that you had a confirmation that you had a virus, you went through a disease course where you were sick, and then you become well and you have antibodies, it's very likely that those antibodies are protective, because the only way that you're going to be able to get over a viral infection is if you produce antibodies that prevent the virus from replicating. Yeah. Right?
There are a few exceptions here, CMV, shingles, or HIV.
So not all antibodies are 100% protective, right? So there's a spectrum in like how protective antibodies can be, right? There's But in general, I think that if you produced antibodies after you were sick, I'm much more likely inclined to believe. So like, let's say that you go get a test and it's positive, and then that person gets a test and it's positive. I'm fairly certain that that person developed antibodies because that's how they would have had to do that to become better. I don't know why. Were you really exposed, or was it a false positive? So I'm not willing to use the results of antibody tests right now to allow somebody that didn't have a known exposure to COVID to go back, to use that as a passport to go and train, or to ignore social distancing guidelines. Now, if you had a person that was symptomatic, had a positive COVID test, got over it, and tested positive for antibodies, if you have a group of those people, I think that that's kind of a special group of people, again, kind of like the people that self-quarantine together, that in a way that they can kind of be outside of the phased guidelines, but they have to be really separate. They're going to be training by themselves. You can provide space for them, but they have to be separate. Now, that's probably not going to be useful for 90% of academies, but if you have an academy that's in a hard-hit area like New York or New Jersey, you might have a significant population of those people, and if you can allow those people to get back to training, I think it's reasonable.
So then what is stage 3 versus stage 4?
So stage 3 is basically like it's the last phase of the Trump guidelines. So you basically are going to stay in that phase, which I think is reasonable because, as testing capacity increases, you might be able to go from having a small group class 1 day a week for people that can go get tested to 2 days a week, and maybe you can get it to 3 days a week. I don't think it's ever going to a point where you're going to be able to do it every day, but I think it's a place, because some people only train 1, 2, 3 times per week. So I think it's a place you can stay for a while. My criteria for stage 4.
Well, so what about instructors in that scenario? Are they getting tested every day?
So no, but not necessarily, right? It's up to the instructor, right? So the instructor might just supervise the class, right? He might just make the pairings. Just, it's like if you go and teach a class, your instructor doesn't train every day. You know what I mean? So maybe it's just on him he's just kind of supervising the pairings. He's giving, okay, today we're going to work on, king of the hill guard passing drills. Today you're going to do 2 minutes of stand up and 5 minutes on the ground, The instructors, if the instructor wants to be able to do that, he can. I don't think there's any requirement that he has to do it though. So for me, phase 4 is basically where, because what's going to really change after phase 3, right? Because you're already having a small group of people sparring. So the next phase would be looking at where you can open it up for most people. Everybody can spar. The only way you're going to be able to do that is if you can confirm in your area that there has been no local person-to-person spread. So you're going to still have active cases in the hospital because somebody that got it 2 weeks ago is still in the hospital sick. If somehow somebody was traveling and they tested positive and you could isolate them and there has been no person-to-person spread from that person, then that also wouldn't count.
So that's called community. Is that the same thing as community spread? Yeah,
community spread. Local, okay. I'm just saying local person-to-person spread or community spread. When you have no community spread for 14 days, and that way, in that 14 days, you've washed out anybody that would have presented that hadn't presented yet. That's the incubation period. At that point, you can say, provided that nobody's traveled outside that area, and of course you have to use some logic, if every area around you is exploding, then maybe it's not a good idea. But if you're in a rural area and you're relatively isolated and all the surrounding counties are kind of the same situation you're in, and you have that 14 days of no local person-to-person spread, I think it's reasonable at that point. I think it's logical at that point to open the academy up for more or less regular training. Now, what I would say is you should still keep the academy, you should still maybe have 50% or fewer of the normal class size. You can still have people register online. And at this point...
Would you still be screening people for temperatures and so on?
No, I don't. I mean, at this... Well, that's a good point. I actually didn't think about that part of this. I think at that point, if you have no local person-to-person spread, you probably aren't going to... The yield on that's not going to be very high.
If you tell people, if you're feeling sick, stay the fuck home.
Right, because, the chance that you're going to be that one person that's still carrying the COVID in a place where you've had no confirmed cases for 14 days, It's very low. But I think I don't have any. If you want to continue that screening process, some people are going to continue that screening process until we get a vaccine, and I think it's reasonable. Again, I'm not looking at the antibodies, right? By that time, the FDA might stamp something and say this is a reliable test that you can use,
for sure,
and it'll allow you to go, and it's safe for you to go and just be out. So
sure.
if that happens, that could change everything. But assuming that doesn't happen, I think it's still going to be a few months away.
Okay. Yeah, and I mean we're embarking one way or the other. Like every state in the union and every province in Canada is going to try some kind of variation of the Sweden experiment, and I hope it goes well. We're gonna see what happens when we reopen in 50 different ways or 60 different ways.
The Sweden thing is it's interesting to me, and I'm not like a connoisseur of epidemics or epidemiologist, but when people talk about herd immunity, it's really interesting looking at like Sweden, or people saying, "Oh, we need to get herd immunity. We get herd immunity." I mean, the way that we've gotten herd immunity in the 20th century is through vaccination, right? That's why we vaccinate people for the flu, right? Because you don't want to have all of a sudden all the people, you might not be particularly susceptible to it. I have a very mild case of the flu, and then boom, I'm spreading it to all these people that can get very, very sick and die, right? So the idea is that you get a high enough percentage of the population immune so that those little pockets of people that you miss or that can't get a vaccine for one reason or another are protected. So we've done that with all sorts of different viruses. So to talk about to develop herd immunity just through like sickness and death is a really strange. It's not typically how we do things.
Yeah, I think we'd better leave that conversation for another day, because that's a huge topic. And then we end up in what I consider to be the false dichotomy between saving lives and saving the economy, and the nuances of what happens if we open up and then it spikes again and then we close, and is that worse? And that's a huge, huge rabbit hole. And I'm already going to get enough hate for hosting this conversation. So, okay. So if all goes well, by the time that there's no community transmission in a reasonably large area around you, that'll kind of be our metric for going to stage 4.
Yeah. That'd be, I mean, the metric for stage 4, again, is based upon your local data, and saying, okay, we've had no community or local community person-to-person spread, whatever you want to call it, for 14 days.
Okay. So the White House guidelines that I'm looking at have 3 stages.
Yeah.
You added stage 4, 5, 6 for jiu-jitsu in particular.
Yes, because I knew that based upon just because you have declining new cases in your area, if you have any new cases in your area, in my opinion, given the intimate nature of jiu-jitsu, it's just not worth it, especially when you have what I hope that you'll have in phase 3 is the availability of being able to train hopefully once or twice per week live. I think that if you're going to throw your hands up and say, well, if I can't train every single day, sweating all over people, and then, it's not worth it, then...
Well, what's good if it is a jiu-jitsu school that is the epicenter of a new epidemic, and you get Tennessee shut down because of it,
Yeah, what was it worth? Yeah.
Well, forget being able to train in phase 1, 2, 3. You're going to have to go all the stage.
And then are your students ever going to listen to anything you ever say again? If you start too early,
The cost of being wrong here is pretty high. So so in phase 4 is regular training based off of local conditions. What are phases 5 and 6?
So phase 4 is basically like most people can come back to train. So there's 2 groups of people that I wouldn't want to come back, because yes, you've had 14 days of no new cases, right? But that doesn't mean that somebody could have traveled, that slid under the radar, but hopefully by that time, any new cases would be able to be contact traced, right? So you have the infrastructure that you can squash, new cases as they pop up. But I still think you want to kind of see what's going to happen after that time period before you invite people that are in those high risk groups to just come back and just roll around with everyone. I think that they should still be
Define high risk.
So the high risk groups, the high risk populations for severe COVID infection. So I don't remember all of them. Diabetes, hypertension, chronic kidney disease, COPD, any immunocompromised, like a specific immunological disease like...
What about a kidney transplant recipient with one kidney who's on immunosuppressants asking for a friend?
Yeah, I think that's probably...
That's not good news at all. Thank you for ruining my life. I mean, my friend's life.
Wow. Okay, we'll have to talk about that another time.
No, it's 5 years ago. A kidney transplant saved my life.
Wow.
So
yeah, that's awesome. I mean,
I'm lucky.
Yeah, it's a better life not being on dialysis.
Yeah, I managed to avoid dialysis.
Wow. So you got a donor before.
Yes, my
so you
brother
got put
gave
on the
my
list
brother.
When you were like stage 4.
I was down to 12% kidney function, so most people get dialysis about 15%.
But you weren't becoming like you weren't uremic and stuff. You weren't developing those symptoms yet.
By less than 15%, you really start not doing too well. Like I was
But
still
you were
alive.
just kind of pushing it off.
Yeah, I was also. I mean, if we could go down that rabbit hole, most people go into kidney failure because of underlying other conditions like diabetes. So I didn't have diabetes or anything like that. So if you're dying of kidney failure because it's your actual kidneys, I had polycystic kidney disease.
Yeah.
Then you can usually go a bit further because there's no other condition.
Right.
And I was also in pretty good shape, but it's funny. I went from 100% to 50% function. I didn't really notice a big difference. 50 down to 30, didn't notice a big difference. Less than 20, 25, that's when you're like, my God, I've been up for 4 hours. I need to take a nap. And I foolishly was still going to work. I just shouldn't have been. But, yeah. So what is 5 and 6?
5 would be, at that point, you can start having those people come back that were immunocompromised or live with someone that's immunocompromised, and they can, train just like everybody else. Up until that point, they're still restricted to the rules from the previous phase, right?
So the reason you don't want to train if you live with somebody who's immunocompromised or elderly is you don't want to bring it home to them.
Right. It's just, you're going to be, this is a person that you're going to be around, intimately with. You're not going to be maintaining social distancing guidelines with someone that lives in your own house. And so I just think it's just I think it's worth what you've waited at this point so long. It's worth waiting a little bit longer to make sure that you're keeping those people safe. So 6 is basically like, 6 is a really unique category. So basically, this is where you're at the stage where the people that were on the front lines actually dealing with COVID patients on a daily basis can come back, right? So this is where the number of active cases actually matters. Prior to this, it didn't really matter, right? But if you were in the hospitals dealing with active cases, right, you have to wait until you've discharged your last patient, and you can have confirmation via, RT-PCR or 14 days. I imagine at this point, anybody's gonna be able to get a test before that person's able to come back. So that's really just specifically for healthcare providers that work on the front lines.
So we owe a huge debt to the doctors and nurses working on the front lines.
Especially if they do jiu-jitsu, because they're going to be the last ones to come back.
Exactly. That's exactly what I was about to say. So they should really get free tuition for the rest of their jiu-jitsu
all the people,
careers.
like if you're hating on, like, not hating, but if you're angry at the doctors for telling you that this is serious, you need to go back and train. If those people are jiu-jitsu, they're the worst off, because they're going to be way after everybody.
Man, this is a complicated process that you've laid out, but I mean, this is a complicated thing, and we're trying to save a sport that's essentially designed to spread infectious disease as efficiently as possible.
Yeah.
I think I'm going to wrap it up. I know it's getting late for you there on the East Coast. Anything else that you want to say?
Thanks for having me on. My only motivation for doing this at all is, just that, I don't make my living through jiu-jitsu, but jiu-jitsu is the thing in my life that allowed me to become what I am, that I used to make a living. So if it weren't for jiu-jitsu, it's a long story that I'm going to talk about. If it weren't for jiu-jitsu, I wouldn't have been able to become a doctor. And so jiu-jitsu is besides my wife and my family, is like the most important thing in my life. And all I really want to do is just make sure that I do right by the community, and that I give people the best information that I can, and just try to keep everybody safe.
Well, while we're waiting for our giant Bitcoin payouts from from the lizards that are controlling this podcast, I'm just going to wish you a good night, and maybe have you on again in the future as the situation changes.
Okay, thanks so much.